Thank you so much for welcoming me, Sue. And it is Beanish. You were right. You kept correcting yourself, but it is Beanish. But I mean, I welcome all abbreviations. My name is what my grandma gave me, my sister and my
Oh,
grandma.
wow.
And it means one with foresight and intelligence. Now, some would debate against that, some may argue for it, but I'm all for both. But thank you so much for a lovely invite and a welcome. I'm just going to do that typical thing where I say, bear with me one moment while I share my screen, everybody. Um, as I said, it's a pleasure to be here and to come and talk about something that's really close to my heart, and something that it's something we've been talking about, and we've had conversations around health inequality and maternity care historically on Netflix, and most recently coming to review the most recent Embrace 2023 report that came out in December, which was two reports. It initially started off at looking at Black babies and perinatal outcomes for Black babies. And then it was further commissioned to be able to look at Asian outcomes as well. And this was in comparison to white counterparts. So you will find there's two separate reports and there's two separate findings. So perinatal outcomes for Black babies in comparison to white counterparts, and again for Asian babies in comparison to white counterparts. I'm going to talk a little bit about both and then give some thoughts and bring out some key points. I was part of the panel that was reviewing this documentation, so I'll bring some insights along the way too. So the reports highlighted the increased risk of stillbirth and neonatal mortality rates for our Black and Asian communities in comparison to their white counterparts. If we look at some of the statistics there, I'm not going to repeat them. You can see them on the screen quite clearly. But the increased risk, so our Black Asian babies are higher risk, are at the highest risk actually of having stillbirths or loss, and that's at 124%. This the highest community, if we break it down by ethnicity, was Black African, and this was despite counting for economic deprivation as well. And then if we look at the Asian outcomes, again, it was our neonatal deaths were higher for our Asian babies, with our Asian Pakistani communities at 59% more likely to have neonatal deaths. So this is the stillbirth rates, and again, the counting, it was accounting for, just got myself all founded about the neonatal death rates, and it again counted for socioeconomic deprivation as well. So these were some of the statistics that came out earlier on. The in detail report we're looking at, antenatal care issues were highlighted, that both Black and Asian women, antenatal care issues were identified at higher rates that could have improved the outcomes. There was also some challenges specifically for our Black families, women and individuals who are accessing maternity care in regards to access, prescription to medications, increased possible lack of engagement, and missing specialist appointments. For our Asian communities, there was a higher risk of pathology issues, for example, not having postmortem after the death, which we know has has can give us answers. And there's some conversations which we can bring up later around this. So these were some of the outcomes highlighted. In reality, there's a lot more in the reports, and I'm not bringing in the specific infographics you mentioned, Sue, because I want people to go and look at the reports. I think it's really important that if you're a midwife, that you look at the reports and those infographics and consider how this falls in line with your role and where you work, and how that might impact the way you work. But some of the key points that I personally felt that I wanted to discuss today were the fact that Black and Asian mothers were having good care. but fewer episodes than their white counterparts overall. So what is good care and how does that look? It was reviewed all the way through from antenatal, birth, postnatal, and bereavement follow-up as well, including follow-up debriefs after loss. So the whole journey was reviewed, and episodes of good care overall were fewer for our Black and Asian communities. What this might mean and how this is reflected is something that we need to consider in our roles. What is happening in our jobs that we are not able to communicate. I think one of the issues that came over and over again was the follow-up letter after a loss that's sent to GPs about what has happened, information sharing. The information is directly talking to the GP, despite this being the same letter that is received by members of the family. So it's talking very medicalized term, it's not very friendly, and it's also not addressing the person who we're talking about, and that's that family. So considering how this might be improved, I know this has been highlighted previously. It's something that we need to think about in regards to future engagement or possible impact it might be having on disengagement. The other issues that were highlighted were the lack of or inadequate use of interpretation services when there are language barriers present. Again, a conversation we've had over and over again. A lot of the time we have systems that have changed and evolved, but after initially bringing in services or equipment into practice, we don't necessarily always have adequate follow-up and updates in training, updates on how to use services, updates on how to address concerns we might have, and active auditing in how effective that service or that equipment is. Generally, we audit everything we do. So why is a key instrument that we need to communicate not being audited? Because if it's not fit for purpose, then we need to address it. Or if it's training that we need, then that needs to be incorporated in. As you can see here, those with the most language barriers were Asian women. I think it fell into the Asian category overall, with Asian, Pakistani, and Bangladeshi women having higher rates of needs for interpreters. Social risk factors were being recorded as less for Asian women, and that's inconsistent with the identification and referral processes across both groups. So we were recognizing and better at recognizing social risk factors and need for support for the white counterparts, but not necessarily so for Asian women and communities. Is this because there's a lack of communication? Is this because there's fear of disclosure? We talk about continuity of care and how important continuity of care is, building relationship, building trust, and being able to disclose social risk factors. Or is this the fact that we're not able to necessarily recognize it because it's something we are looking for factors that are Eurocentric, and maybe someone's presenting in a different way due to culture, or disclosing something in a different manner using different terminology which we're unfamiliar with. Uptake of antenatal screening for chromosomal conditions was lower in Asian communities, with a higher percentage of declining for screening in comparison to our white counterparts. Now, again, is this a communication issue? We know some of our communities are having higher rates of chromosomal genomics, genetics needs. So working with our communities, co-producing the services to make sure that they're adequate for the needs of those communities, so they are sensitive and we're able to broach them, may help us address some of these concerns because it may impact future pregnancies. We know that people who have losses are likely to come back and have future pregnancies. Having the preconception care and support is really important here. Poor recognition of personal challenges, which is especially true for some of our white counterparts and white women that we review documentation for. I always think that, yes, we've been talking and highlighting how recording ethnicity is vital and important in everything we do. But I remember when I was working clinically, and I tried to make a change in the system to recognize our traveller Gypsy Roma communities, Eastern European communities, because they are also marginalized groups. They also have barriers to access. Antenatally, we inputted it, so the system had to, so that midwives could pick up that information and put it in, and we could hopefully follow their outcomes. However, at the time of birth, the spine at NHS England would recognise that because it didn't translate. So at time of birth, it would revert back to white or white other, which means their outcomes became diluted into this larger pool of data. So really, we don't know what's happening there, and I suspect, but I cannot confirm with the data, that this is something that is from our marginalised white communities that we are seeing there that's not being recognised and not being addressed. We saw the fact that there was fewer blood tests offered for gestational diabetes for Black and Asian women, and actually commencement of vitamin D, there was no commencement for Black women, even though we know that the more melanin you have in your skin, the more likely you are to be vitamin D deficient, and only 1 in 10 Asian women were being commenced on vitamin D. Vitamin D is important for everyone's health, in your long-term health, in your quality of life. It's also really important in pregnancy when you're growing a little human, and their bones and their development and their future development as well. So really vital things that are not happening. And we've mentioned this before, but I just really wanted to reiterate that access and the barriers to accessing that were identified for Black women, and the lack of personalised care was recognised too. So these are my thoughts and what's come up for me from being on the receiving end and looking at it from the report as a final product, but also being on the other side and having been part of the process for this specific report for perinatal outcomes. I feel like it's really important to talk about the iceberg, and actually what we are seeing is the very, very tip. And I thought when I started this that it'd be so, I'd be able to look at the data and find the answers, because I really like to pick at data and try to unpick, to understand what's happening behind the scenes. But unfortunately, the reality is the data we have is what we document. And we know a lot of things we do not document because we do not have the capacity to, or the systems do not allow it. We are going technological, and some of the things are that the IT data and the digital data that was coming in was either insufficient or not being documented to the full effect, as if someone was handwriting. I know that if I'm handwriting, I can write. And I was one of those midwives. I would write essays. Oh God, that's flashback to essays earlier in the week that I was writing. But yeah, I can write essays. However, if I'm typing something, I'm likely to write less. So what are we missing out in that data? Also, what we document is what is being done, what is accepted, what is declined, but not necessarily the conversations and the nuanced, the nuances of that conversation, the non-verbal, the possible things that are giving us an idea of what's actually happening. So we can't really unpick that. So we can get outcomes, we can get data. It's being shared, it's being disseminated. We can see what complaints are coming out in the media, in the articles. We can see the complaints that might be coming out through our PALS complaints procedures. But who's more likely to complain? When I looked at the local data in the previous trust I worked at, even though our Asian community in that locality was 30%, less than 1% of the complaints were from the Asian community. So really, our communities are less likely to complain. And then the documentation is what we're looking at that helps us get a little bit of that understanding, but the lived experience isn't there. If people have disengaged, we don't understand why they've disengaged. And ultimately, we know what the data says about years of ill health comparison versus, on average, it can be 7.6 0.5 years of your life expectancy that can differ from you if you're living in a socioeconomically deprived area versus an affluent area. We know that if you're living in those same areas and you're Black or Asian, you're likely to have higher rates. So you're more likely to have lower years of ill health in comparison to your white neighbor. So what, what is that data really saying to us, and how are we unpicking it, and what are we finding out? The limitations of the study was that we need to find the other side. We need to hear the voices, and I'm so glad Julia's here to follow up with those voices and tell us those experiences that can directly give us some improvement. But also, as a midwife, as someone who's passionate, and as someone who's had these conversations over and over again, I would encourage you to go and look at the report, look at the recommendations that have been made in the report, look at, if you are a researcher and want to do research in this, look at the gaps so that we can start to understand the nuance behind it and start to address that. And ultimately, when we are practicing, it is us as a professional with someone who needs our services. There is a power dynamic there, unfortunately. We might not think it's there. We might not treat it like it's there. We wear a uniform most of the time. We are a person of authority. So the reality is, someone may have experienced something before us that's made them less likely to trust us as a healthcare professional, or someone's heard something that's not been great, or they culturally are less likely to be able to engage because of the way they socialize, the way they've been brought up, and it takes time to build. So when you're providing care, do that extra little bit. And I know it's really hard to do, and I know you're doing everything you can do right now, but something's not happening really well for our communities at the moment. And as someone from a South Asian community who knows that I've had people come up to me as soon as they know that I'm a midwife, just to share their experiences with me. When I ask them back about did you complain, or did you raise this, or did you tell your midwife, they say no because they don't feel like they were able to. So ultimately, we don't know what we don't know, but how we approach each conversation and how we appear each time means that the person in front of us will or won't engage with us. So just being reflective in our practice, being sure that we're offering all options, being sure that people are giving the pros and cons, and we are not, if we think of Montgomery v. Lanarkshire, we need to give those options for people to make the decisions they need to make that's right for them. And when we're not giving it, we are going to be impacting someone's health and their outcomes, unfortunately. So, okay, I'll stop talking there. I'll have a little breather. Thank you. Thank you for listening. I'm sure we're going to have some conversations later. So I'm just going to stop sharing and hand over and hopefully speak to you on the other side.